Welcome to the Lecturette, Comparing Health Systems Response to COVID-19. Dr. DeShore is a DHA graduate, cohort 2014, completing her dissertation in February 2020 on the impact of global health governance on transnational health security threats and evaluation of the Global Health Security Agenda Steering Group. She also completed the Graduate Certificate in International Health. Dr. DeShore has served on several clinical staff officer positions at Walter Reed National Military Medical Center, currently as a service chief and pediatric nurse practitioner for the Pediatric Sedation Unit. Retired from the Air Force Reserve's Nurse Corps, Lieutenant Colonel DeShore served in a wide variety of senior medical positions throughout her 28-year career, her last duty assignment as the Chief Nurse Executive, Maxwell Air Force Base, Alabama. Please feel free to reach out at any time, ndeshore@gmail.com, or cell 240-441-3736. This lecturette will cover the history of pandemics, COVID-19 progression, confirmed COVID-19 cases with country comparison trajectories, and comparing health system responses for United Kingdom, Germany, Singapore, Taiwan, and Canada. Each of the outlines on countries is from data and written material offered at the time of writing of this lecturette. Peer-reviewed publications or journal-published literature is very limited at this time. Dr. Johnson will provide the PowerPoint lecturette with speaker notes to be included. The notes for each of the countries will include direct links to the resources used in the lecturette. As humans have spread across the world, so have infectious diseases. Widespread trade created new opportunities for human and animal interactions that speed up epidemics. Even in this modern era, outbreaks are nearly constant, though not every outbreak reaches pandemic levels as the novel coronavirus, COVID-19, has. In our interconnected worlds, we are only as safe as the most fragile state. Challenges recognized within and across nations makes pandemic response even more dependent on international cooperation and the willingness of all countries to take steps to tackle threats to health security and health system response. In 2003, a novel coronavirus, the etiology of a mysterious pneumonia, also originated in Southeast China and was named SARS coronavirus. The mortality rate caused by this virus was around 10 to 15%. In 2012, a novel coronavirus in the Middle East shared similar features with the outbreak in 2003. Both were caused by coronaviruses, but the intermediate host of MERS was thought to be a dromedary camel. The mortality rate caused by this virus was 37%. COVID-19 was first reported in Wuhan, China in December of 2019. On January 12, 2020, the World Health Organization confirmed that a novel coronavirus was the cause of a respiratory illness in a cluster of people in Wuhan City, China, which was reported to the World Health Organization on December 31, 2019. As we look back at the early days of the spread of the pandemic, countries that were proactive in taking strict steps prohibiting social gathering, such as Singapore and South Korea, managed to bring the pandemic under control swiftly. Singapore, Japan, Taiwan, and South Korea all share the characteristics of using their experience with prior outbreaks to build a system and then sustaining it. Their countermeasures were already in place and waiting to be reactivated. Limited testing and challenges in the attributions of the cause of death means that the number of confirmed deaths may not be as accurate account of the true number of deaths from COVID-19. When comparing the data and attempting to know how different countries' epidemics stack up against each other, we need to be aware that nations have different reporting standards, different approaches to testing, and different approaches to tracing cases, all of which make such comparisons dangerously misleading. Testing and reporting have been inconsistent even in individual countries and internationally. Rules on who gets tested, where and when can evolve, and these changes and time lapses are not necessarily captured in the data published by different governments. Without widespread testing, COVID 19, we can neither know how the pandemic is spreading nor appropriately respond to it. Internationally, the comparisons rely on piecemeals of different sources. The Johns Hopkins University map has become the go-to resource for many media organizations and experts, which pulls data from the World Health Organization, the US CDC, the European CDC, and China's National Health Commission, in addition to local media reports, health departments, and an online community of healthcare professionals. Rather than focus too much on the actual numbers, scientists are spending their time looking at the epidemic curve, the shape of the graph that captures the total number of new cases in each country day by day. If different nations have different standards and conditions, the goal is to generate a consistent curve if these standards and conditions are stable across time. As of April 18th, the United Kingdom has had 115,341 confirmed cases, 15,493 deaths, and 414 recovered cases. Of note, more than 90% of the dying are elderly or have had underlying illnesses. Keep calm and carry on was the public face of the UK's government's response to COVID 19. Behavioral scientists were warning that fatigue with strict infection control measures would set in if they were triggered too soon. As late as the second week in March, there was no banning of mass gatherings on the basis of a statistical modeling that doing so would have minimal impact. On March 12th, Prime Minister Johnson held his first major press conference on the issue, flanked by his chief medical advisor and his chief science advisor, where they offered no recommendations and far less any instructions to shut down one of the busiest weekends on the sporting calendar. With that, more than 250,000 people gathered at an annual horse racing carnival in Cheltenham, England. Tens of thousands of Scottish fans were able to travel to Wales by car, bus, and train through England for a Scotland-Wales rugby match. And many more tens of thousands were set to travel up and down the country to attend soccer matches. The lack of government action in the second week of March was also completely out of step with almost all other European countries. On 26 March, the UK had pursued a strategy of mitigation rather than suppression, focusing on ensuring that those with symptoms stayed home to protect the most vulnerable in the population. Daily life continued more or less unchanged. The strategy, again, was based on the idea that introducing stringent measures too early would cause behavioral fatigue, making the lockdown ineffective just as it was most needed. According to the government's initial approach, it was crucial that suppression be timed to coincide with the peak of the coronavirus curve. This thinking changed when a new model emerged from the experts at the Imperial College of London. It suggested that a mitigation strategy of this sort pursued by the government would mean 250,000 lost lives, more than double the previous guess. There had been a call for the UK government to run more coronavirus testings and provide more meaningful data. The UK government says that the health system didn't currently have the capacity to test everyone who had COVID-19 symptoms. Only sick patients requiring hospitalization treatment could get tested. The relatively low number of tests done in the UK helps explain why the case numbers appear so much lower in mapping models compared to other European countries. Potential scenarios in the interventions modeled targeted herd immunity, only isolate necessary vulnerable parts of communities and populations. The first revelation that the government might be looking at creating a herd immunity came on the 11th of March when the chief executive of the Governmental Behavioral Insight Team made statements to the press. No physical distancing measures were in place at that time. All schools, workplaces, pubs, restaurants, and social events were still open and going ahead, and the government's only advice was that people with COVID-19 symptoms should self isolate for a week. On 28 March, the chief editor of the Lancet published a condemnation of what he saw as a government's inaction and ignoring of WHO's advice. On April 2nd, the Telegraph reported that one of government's science advisors claimed that mass public testing had never been a strategy for the pandemic. He also claimed that the government didn't want to invest millions of pounds in something that was about preparedness. The data on Germany, current as of April 18th, was confirmed cases of 143,724, recovered cases of 85,400, and deaths of 4,538. German Disease and Epidemic Control is advised by the Robert Koch Institute, RKI, according to a national pandemic plan. The outbreak was first managed in a containment stage, which attempted to minimize the expansion of clusters. The German government and several health officials stated that the country was well prepared and at first saw no need to take special measures to stock up or limit public freedom. Since March 13th, the pandemic had been managed in a protection stage as per the RKI plan, with German states mandating school and kindergarten closures, postponing academic semesters, and prohibiting visiting to nursing homes to protect the elderly. 2 days later, borders to the 5 neighboring countries were closed. On March 22nd, the government announced a national curfew, which included limiting individuals from leaving their quarters except for commuting to work and purchasing groceries, and not in a group of more than 2 if they did not share the same household. Germany has a common national pandemic plan which describes the responsibilities and measures of the healthcare system actors in the case of a huge epidemic. Epidemic control is executed both by the federal authorities, such as the RKI, and by the German states. The German states each have their own epidemic plans. In March, the national plan was extended for the handling of the ongoing coronavirus pandemic. 4 major targets are included in this plan, which are reduce morbidity and mortality, ensure treatment of infected people, upkeep of essential public services, and short and accurate information for decision makers, media, and the public. The plan has 3 stages which might eventually overlap, which are containment, protection, and mitigation. Criticisms towards Germany's plan. As early as January 2013, the Federal Office of Protection and Disaster Assistance never set up appropriate stores or had talked with manufacturers and suppliers to prepare for such a situation per the National Pandemic Plan. In widespread availability of lab tests, but due to the restrictive RKI testing criteria, Germans without any or unspecific symptoms could not be tested until March of 2020. Incubation periods and turnaround time for the only diagnostic test, the PCR, led to reporting lags of up to 5 to 10 days. Because of the federal health care system in Germany, states vary in data collection, aggregation, and time of release to the public. Release of official numbers caused an additional delay of several days. Impacts on the number of deaths. Germany decreased the uncertainty about the proportion of asymptomatic affected and brought the calculated mortality rate closer to the actual mortality rate, which was lower. Germany has no routine postmortem tests, which may lead to not discovering all deaths. The elderly in Germany often do not live in large families, which reduce infections, and Germany has many testing labs and a weekly testing capacity of 160,000. Singapore's coronavirus data as of April 18th confirmed cases 5,992. Recovered cases, 740. Deaths, a total of 11. To combat COVID 19, a multi ministerial committee was formed on January 22nd with the Minister of National Development and Minister of Health as the co chairs, and the Prime Minister, Deputy Prime Minister, and Minister of Finance as advisors. Singapore promptly instituted an international travel ban around the same time as their first confirmed case, followed by very strict screening and quarantine measures. In 2002-2003, severe acute respiratory syndrome, the original SARS, tore out of China and through Asia, killing 33 people in Singapore and sparking wholesale revisions to the city-state public health system. Singapore instituted new travel controls and health infrastructure. Then, in 2009, it got hit again with H1N1 influenza, the swine flu. Singapore tried to put in place in 2009 what they learned from SARS, but flu was much more difficult to contain than SARS, and they realized what they thought they learned didn't work. With COVID 19, Singapore instituted strict travel controls and protocols for identifying sick individuals to get them help as well as find the people that they've been in contact with. The Singaporean government posted detailed accounting of how many people had been infected with the virus, the location and natures of these people's social contacts. All these governments instituted strict social distancing measures, canceling events, closing schools, and telling people to stay home. Singapore developed their own test for COVID 19 as soon as the genetic sequencing for the virus was published and ramped up production of the necessary material for the test. They also instituted controls over immigration. Additionally, they re engineered their national finance system to make sure people didn't have to pay for tests or treatments. People in Singapore, for now, get their information from multiple government websites, frequently updated, as well as from the government WhatsApp account. Singapore's digital approach addresses all four stages of an epidemic: surveillance, prevention and containment, diagnosis, and treatment. The government employed extensive contact tracing using digital technology. People get their temperatures taken before they can enter most buildings, including businesses, schools, gyms, and government agencies, because fever was one of the main symptoms of COVID 19. The people believe there is confidence in this information, in the government, and what they are saying, and there are expectations of what they should and should not follow. In at least one hospital, the experience of SARS led to the complete reimaging of the way physicians deal with patients. Singapore General Hospital keeps teams of healthcare workers separate from one another in case one has to be quarantined. A physical separation of different kinds of patients, all sorts of seemingly small systematic changes that limit the spread of an infectious disease. On April 3rd, Singapore announced a stringent set of preventive measures that were collectively called a circuit breaker, which was a partial lockdown. The government aimed to slow down the spread of the virus by allowing only services which were essential or strategic to continue, such as closures of most workplaces except for essential services and key economic sectors. They offered stimulus measures to boost the economy and had further school closures. Taiwan's coronavirus data as of April 18th: confirmed cases 398, recovered cases 178, confirmed deaths 6. In 2004, after the SARS outbreak, the Taiwan government established the National Health Command Center. The National Health Command Center is part of a disaster management center that focuses on large outbreak response and acts as an operational command point for direct communication among central, regional, and local authorities. On January 20th, when China had reported only a few cases of the disease, Taiwan spun up a central epidemic command center, created again after SARS, to coordinate the national effort. Among other things, the Central Epidemic Command Center put limits on the prices of personal protective equipment like masks and deployed military personnel to manufacture more. Taiwan's equivalent to the U.S. CDC announced that it had 44 million surgical masks, 1.9 million N95 masks, and 1,100 negative pressure isolation rooms ready to go. Taiwan quickly mobilized and instituted specific approaches to case identification, containment, and resource allocation to protect public health. Taiwan leveraged its national health insurance database and integrated it with immigration and custom databases to begin the creation of big data for analytics. It generated real-time alerts during a clinical visit based on a travel history and clinical symptoms to aid case identification. It also used new technology, including QR code scanning and online reporting of travel history and health symptoms, to classify travelers' infectious risk based on flight origin and travel history in the past 14 days. People with low risk were sent to health declarations, boarding passes via SMS, messaging to their phone for faster immigration clearance, and those with higher risk were quarantined at home and tracked through their mobile phones to ensure that they remained at home during the incubation period. A toll-free number served as a hotline for citizens to report suspicious symptoms or cases in themselves or others. As the disease progressed, this hotline had reached full capacity, so each major city was asked to create its own hotline as an alternative. The government additionally addressed the issues of disease stigma and compassion for those affected by providing food, frequent health checks, and encouragement for those under quarantine. Canada's coronavirus data as of April 18th, their confirmed cases was 34,385, recovered 10,965, and deaths were 1,403. Canada's response to severe acute respiratory syndrome SARS in 2003 pushed the country to invest in testing and monitoring infrastructure to prepare for future influenza pandemics. Canada developed decentralized federal, provincial, territorial approach to expand the country's capacity to monitor potential cases, conduct tests, and validate tests at the local level. Thus, Canada's ability to identify cases early and tracing the sources of infection was key to minimizing the spread of COVID-19 early on. Canada's COVID-19 response working group, who had been meeting since the end of January to prepare for broader transmissions of the virus, was elevated to a cabinet committee. The committee's role is to guide the country's leadership, coordination, and preparedness efforts to limit the health, economic, and social impacts of the virus. Health Canada began holding daily news briefings as to provide Canadians with the latest information regarding the virus. The Canadian federal government's pandemic response is based on two primary documents: the Canadian Pandemic Influenza Preparedness Planning Guidelines, which outlines risks and measures to address the viral disease, and the Federal, Provincial, Territorial Public Health Response Plan for Biological Events, which includes identifying, tracking, and ensuring rapid access to medical care. The federal government activated its Emergency Operations Center on January 15th. On February 27th, the response plan was elevated to Level 3, and airports raised awareness of the virus and added a health screening question to electronic kiosks for passengers arriving from central China. On March 6th, the Canadian federal government offered $27 million in funding to 47 research groups at 19 universities to develop means for managing the outbreak. On March 18th, the Federal Minister of Health announced that the federal government had signed an interim order to speed up access to COVID-19 tests kits that would allow provincial labs to increase testing. On March 19th, $275 million in funding was added to an additional 49 projects to bring to a total of 96 research projects that would focus on developing and implementing measures to detect, manage, and reduce the transmission of COVID-19. On March 23rd, Canada announced support for quickly mobilizing Canadian researchers and life science companies to support large-scale efforts towards countermeasures to combat COVID-19, including potential vaccines and treatments. In mid-March, as cases of community transmission were confirmed, all of Canada's provinces and territories declared states of emergencies. Provinces and territories, to varying degrees, implemented school and daycare closures, prohibited gatherings, enclosures of non-essential businesses, restrictions on entry, and mandatory self-isolation for travelers. Canada severely restricted its border access, barring travelers from all countries with some exceptions. The Federal Ministry of Health invoked the Quarantine Act, legally requiring all travelers, excluding essential workers, returning to the country to self-isolate for 14 days. On March 22nd, mandatory self-isolation was imposed federally, making it a legal requirement for all provinces who had not done so already. On April 2nd, Canada launched Canada COVID-19 app to provide Canadians with the latest information on COVID-19 and a way to check their symptoms. Hospital crowding constituted the single greatest challenges for Canadian hospitals. The safe occupancy rate for any one hospital hovered at around 85%. Generally, this figure had already accounted for a built-in surge capacity should any unforeseen outbreaks of disease, natural disasters, or accidents occur that would require increased demand for healthcare services. Yet, for the past 20 years, Canadian hospitals have been functioning at 100% capacity and more daily. Supply chain disruptions, principally because of China's position in the global supply chain, provided 10% of the unfinished products that were used in the production of final goods in Canada. This shortage had the potential to affect 4.4 billion of medical instrument and supply manufacturing in Canada's industry with the shortage of raw material and supplies. The last 6 slides do not have a narrative attached. They have been added to show you the graphic representation and comparison between the countries, with the United States added since you are very familiar with the United States and the topic that is attached to the slide. Thank you for this opportunity to present and to have you listen to this lecturette. Please feel free to reach out with me with any comments.